Welcome back to Nephrology Notebook. Today we are breaking down the SCORED trial, a major study of sotagliflozin in patients with type 2 diabetes and chronic kidney disease. The key question is practical. Can SGLT inhibition reduce cardiovascular and heart failure events in CKD patients who do not necessarily have heavy albuminuria? That is the clinical gap SCORED tried to answer. The take-home message is that sotagliflozin lowered the total burden of cardiovascular death, heart failure hospitalization, and urgent heart failure visits in patients with type 2 diabetes, CKD, and cardiovascular risk. The important nuance: cardiovascular death alone was not significantly reduced. The strongest signal was heart failure related, and the trial matters because patients were included with or without albuminuria. Let's anchor this with Susan, a 69-year-old with long-standing type 2 diabetes, hypertension, prior MI, moderate CKD, and only macroalbuminuria. Her eGFR is about 45, her UACR is 80, and her EF is preserved. Before SCORED, clinicians might ask, is she albuminuric enough to benefit? This is exactly the type of patient the trial helps us think through. The evidence gap was albuminuria. Earlier kidney outcome trials often focused on patients with high albuminuria, where kidney risk is obvious and event rates are high. But diabetic CKD is heterogeneous. Many patients have reduced eGFR with normal or mildly elevated albuminuria. SCORED asked whether cardiovascular and heart failure benefit could extend across that broader albuminuria spectrum. This is the epidemiologic point. In SCORED, about 2/3 of enrolled patients did not have macroalbuminuria. Roughly 1/3 had normal albuminuria, 1/3 had microalbuminuria, and 1/3 had macroalbuminuria. That distribution is clinically important because it mirrors the patients we see in clinic and on the wards. High-risk CKD without necessarily massive proteinuria. Diabetes plus CKD creates a high-risk cardiovascular phenotype. These patients are vulnerable to heart failure, ischemic events, and kidney decline at the same time. The biology overlaps: sodium retention, vascular disease, myocardial stress, and nephron loss. SCORED is not just a glucose-lowering trial. It sits at the intersection of metabolism, kidney disease, and cardiovascular risk. The clinical trajectory starts with chronic hyperglycemia and glucotoxicity. That promotes oxidative stress, sodium retention, and maladaptive kidney hemodynamics. Over time, patients develop volume sensitivity, heart failure risk, and progressive nephron loss. The therapeutic idea behind SGLT inhibition is that a single intervention may touch multiple pathways: glycemia, natriuresis, tubuloglomerular feedback, and cardiac loading conditions. Standard therapy matters. RAAS blockade, glycemic control, and statins remain foundational. But even on contemporary care, patients with diabetes and CKD have substantial residual risk. In SCORED, most patients were on RAAS inhibition, yet cardiovascular and heart failure events still occurred. That residual event rate created the rationale for testing an additional cardiorenal therapy. SCORED focused on two missing pieces. First, can SGLT inhibition help CKD patients who are not selected for macroalbuminuria? Second, does dual SGLT1 and SGLT2 inhibition add a clinically relevant mechanism through the gut as well as the kidney? Sotagliflozin was designed to test that dual pathway hypothesis. Sotagliflozin inhibits SGLT2 in the kidney and SGLT1 in the intestine. The kidney effect increases urinary glucose and sodium excretion. The gut effect delays intestinal glucose absorption and may blunt postprandial glycemic excursions. That dual mechanism is what separates sotagliflozin from more selective SGLT2 inhibitors and sets up both the potential benefits and the adverse effect profile. In the proximal tubule, SGLT2 normally reabsorbs filtered glucose along with sodium. Blocking SGLT2 promotes glucosuria and natriuresis, and it can restore tubuloglomerular feedback. Clinically, that may reduce intraglomerular pressure and cardiac volume stress. For SCORED, the most convincing clinical signal was not a hard kidney endpoint, but a reduction in heart failure-related events. SGLT1 inhibition works mainly at the intestinal brush border. By delaying glucose and galactose absorption, sotagliflozin can blunt post-meal glucose excursions. This mechanism may remain relevant when eGFR is lower, because it is not dependent on filtered glucose load. But the gut mechanism also explains why diarrhea was more common with sotagliflozin than placebo. The adverse effects make mechanistic sense. Gut SGLT1 inhibition can lead to osmotic GI symptoms, especially diarrhea. Kidney SGLT2 inhibition causes glucosuria, which increases genital mycotic infection risk, and natriuresis, which can contribute to volume depletion. Like other SGLT inhibitors, there is also a small but important diabetic ketoacidosis signal requiring sick day counseling. SCORED began as a large cardiovascular and kidney outcomes trial, but it was disrupted by early loss of funding during the COVID era. Final visits were initiated before the planned number of events accrued. While investigators remained blinded, the primary endpoint was changed to a total events endpoint to preserve interpretability. That adaptation is central to both the trial's value and its limitations. The design was straightforward. Over 10,000 patients with type 2 diabetes, CKD, and cardiovascular risk were randomized to sotagliflozin or placebo. The starting dose was 200 mg daily, with titration to 400 mg if tolerated. Median follow-up was only about 16 months, and the analysis followed the intention to treat principle. The enrolled population is the major strength. Patients had type 2 diabetes, HbA1c at least 7%, eGFR 25 to 60, and additional cardiovascular risk. Importantly, macroalbuminuria was not required. Patients could enter with normal, micro, or macroalbuminuria. That makes SCORED highly relevant for real-world diabetic CKD, where albuminuria is often modest. Baseline characteristics show why this trial is different. Median age was 69, median eGFR was about 44.5, and median UACR was only 74 mg per gram. That is, microalbuminuria, not nephrotic range proteinuria, and not the very high albuminuria seen in some kidney outcome trials. SCORED therefore tested a population that many prior kidney trials did not emphasize. Because follow-up was truncated, SCORED used a total events analysis for the revised primary endpoint. That endpoint counted cardiovascular death, hospitalization for heart failure, and urgent visits for heart failure. Unlike a time-to-first event design, total events analysis allows recurrent events from the same patient to contribute. This better reflects the clinical burden of heart failure, but it also complicates comparison with traditional trials. Here is the primary result. Sotagliflozin reduced total cardiovascular death and heart failure events from 7.5 to 5.6 events per 100 patient years. The hazard ratio was 0.74, with a confidence interval from 0.63 to 0.88. That corresponds to a 26% relative reduction in the revised composite endpoint over relatively short follow-up. SCORED also examined traditional atherosclerotic events, cardiovascular death, non-fatal myocardial infarction, or non-fatal stroke. Sotagliflozin reduced the first occurrence of this MACE endpoint, with a hazard ratio of 0.84 and a confidence interval just below 1. This suggests the benefit was not limited to heart failure events. However, the mechanism is not proven from this slide alone, so we should avoid claiming a distinct anti-ischemic pathway. The original co-primary endpoint of cardiovascular death or hospitalization for heart failure also favored sotagliflozin, with a hazard ratio of 0.77. This supports the broader SGLT inhibitor pattern. Heart failure benefits often emerge early. Clinically, that matters because CKD patients are frequently volume sensitive and face high rates of decompensation. Not every endpoint improved. The hard renal composite was not statistically significant, and all-cause mortality was unchanged. That does not prove absence of kidney benefit. The trial was shortened and had limited kidney event accrual. But it does mean we should avoid calling SCORED a definitive renal protection trial. Its strongest evidence is cardiovascular and heart failure risk reduction. The subgroup analysis suggested that the primary benefit was broadly consistent across normo, micro, and macroalbuminuria. That is clinically important because it supports not using albuminuria alone as the gatekeeper for SGLT inhibition in diabetic CKD. However, subgroup analyses were not adjusted for multiple comparisons, so this should be framed as consistency of effect, not definitive proof of albuminuria independence. The safety trade-offs were predictable and clinically actionable. Diarrhea, genital mycotic infections, volume depletion, and DKA were more common with sotagliflozin. The practical response is not to ignore the drug, but to prescribe thoughtfully. Assess volume status, review diuretics, counsel on genital symptoms, and provide clear sick day rules for ketosis risk. The strengths are substantial. SCORED enrolled a broad CKD population, including patients without macroalbuminuria. It tested a dual SGLT1/2 inhibitor and demonstrated a significant reduction in the revised total cardiovascular and heart failure endpoint. It also used a total events framework, which captures recurrent heart failure burden better than a single first event approach. The limitations are equally important. The trial stopped early because of funding loss, median follow-up was short, and final endpoint adjudication was not completed. Investigator-reported events were therefore used for final analyses. The primary endpoint was changed while blinded, which was methodologically defensible, but it still makes the trial more complex to interpret than a conventionally completed outcomes trial. For practice, SCORED supports an important principle. Diabetic CKD patients with reduced eGFR and cardiovascular risk may benefit from SGLT inhibition even without macroalbuminuria. The safest way to frame this is not everyone needs sotagliflozin, but rather Do not wait for severe albuminuria before considering evidence-based SGLT therapy in an appropriate patient. Back to Susan. She has type 2 diabetes, moderate CKD, prior MI, preserved EF, and macroalbuminuria. SCORED tells us she resembles a population that benefited from sotagliflozin on cardiovascular and heart failure outcomes. The management move is to consider SGLT inhibition, review contraindications, counsel on GI symptoms and DKA sick day rules, and monitor kidney function and volume status after initiation. 3 teaching pearls. First, albuminuria is a risk marker, but it should not be the only trigger for SGLT therapy in diabetic CKD. Second, sotagliflozin's SGLT1 effect gives it a gut signature, especially diarrhea. Third, the most robust and rapid benefit in SCORED was heart failure related, so think of these drugs as cardiorenal therapies, not just glucose-lowering drugs. The final takeaway. SCORED showed that sotagliflozin reduced the total composite of cardiovascular death, heart failure hospitalization, and urgent heart failure visits in patients with type 2 diabetes and CKD, including those without macroalbuminuria. It did not definitively reduce CV death alone or hard kidney endpoints. Thanks for watching Nephrology Notebook. Subscribe for more practical nephrology trial breakdowns.